Thank
Thank
you.
you.
Oh, my team's shut down. Uh-oh. My communications with Julie's been cut off because my teams went. Thank you so much.
I'd like to have the board to go back into session, and it's currently 12:47. And to start off really with now settlement agreements.
This conference will now be recorded.
So I'd like to go ahead and move forward with settlement agreements. And we will start first with JLB RCP. Do I hear a motion to ratify the proposed permanent surrender with JLB RCP?
So moved, Dr. Johnson.
Dr. Johnson. Second,
Sorry.
Dr.
Correct. Second.
We'll go ahead with a roll call. Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Schonstein,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Reddy,
Yes.
and Dr. Bechtel, yes. We'll now go to JMHMD. Do I hear a motion to ratify the proposed consent agreement with JMHMD? Do I have a motion, please?
So moved, Dr. Cacarella.
Dr. Cacarella, thank you. Second?
Second, Dr. Johnson.
Dr. Johnson, second. Thank you. Roll call. Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Schonstein,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Reddy,
Yes.
and Dr. Bechtel. I have to abstain in this case, so abstain. We'll now turn to LMMD. Do I hear a motion to ratify the proposed permanent surrender and retirement with LMMD? Do I have a motion?
So moved, Dr. Cacarella.
Dr. Cacarella, motion. And second?
Second, Dr. Johnson.
Thank you, Dr. Johnson. Roll call, Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Schonstein,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Reddy,
Yes.
and Dr. Bechtel. I have to abstain in this case. Thank you. We'll now go to provider VDRDO. Do I hear a motion to ratify the proposed consent agreement for VDRDO? I'll need a motion.
So moved, Dr. Cacarella.
Second?
Dr. Johnson.
Thank you, Dr. Johnson. We'll have a roll call. Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin.
Yes.
Thank you. Dr. Schonstein,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Reddy,
Yes.
and Dr. Bechtel. I have to also abstain on this case. Thank you.
I'm sorry, Dr. Bechtel, did we do the, unless I missed it, did we do the proposed settlement on PGB MD? Which should be in the updated script.
Actually.
Oh,
I don't have my script at all.
okay, I sent you, there's, if you don't have it handy, there's a script that I emailed this morning earlier in the meeting. But actually, I could read from it, or another board member, or if you just want time to pull that up, that would be fine.
I could have Dr. Schottenstein do that.
My pleasure, thank you. Do I hear a motion to ratify the proposed permanent surrender with TGBMD? Motion, please.
So moved, Dr. Cacarella.
Thank you. Second.
Dr. Johnson?
Thank you, Dr. Johnson. Roll call, please. Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Sohn,
Yes.
myself, Dr. Schottenstein, yes. Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel. Sorry,
Yes.
Dr. Feibel. Thank you so much. And Dr. Bechtel.
Abstain. Thank you, Dr. Schottenstein.
Pleasure. Thank you.
Now we'll go to notices of opportunity for hearing, orders of summary suspension, orders of immediate suspension, and orders of automatic suspension. Ms. Canepa, who's the Director of Investigations, Enforcement, and Compliance, will now present the proposed citations to the board. Angela?
Thank you. The first matter is in the matter of RB. It is a predetermination site involving a licensed massage therapist applicant for failure to appear at a scheduled exam in November of this year, and giving us no reason why she did not appear.
Do we have a motion?
So moved, Dr. Cacarella.
Second?
Second, Dr. Johnson.
Thank you, Dr. Johnson.
I'm sorry, are we going to, I'm sorry, this is Benton again, I hate to interrupt. Are we going to go through all the citations first and then vote on them according to the script?
Okay, okay.
Or, we can actually do it however you would like, but that's been the norm for a while.
We can go through the standard ones, yeah. If you'd like to go back and go through all the citations, that would be fine. Yeah, thank you.
Okay. The second one is in the matter of BC, B as in boy, C as in cat. Again, a licensed massage therapist applicant who failed to appear for his exam. This individual actually indicated that he could not afford it and wanted to withdraw his application. However, our procedures don't permit that. So this is a move for site failure to appear at the exam and presumptive impairment. The next one, do you want me to take questions at the end also, if there are any questions?
Yes, that'd be fine, Angela. Thank you.
Okay. The next one is in the matter of RN. Again, this is a failure to appear for an exam in November of this year for mental health issues. This is actually a physician who already has a license, so there is an accompanying request for summary suspension given the imminent danger to the public if she were to continue practicing. And then the next one is in the matter of BO. This is a request for a citation due to the fact that he was convicted in November of 2020 in federal court for felonies related to his practice. And then the last one is NW. And this is a request for a citation based on a number of violations. As you can see, there are 10 patients included here. There were 2 different experts obtained in this matter, and they concluded that failed to maintain minimal standards, both in practice and in regards to prescribing drugs, using prescription drugs for treatment of irretractable pain and for chronic pain, and violation of the ORS system.
Last, ask the board if there's any questions for Ms. Canepa in regards to any of these citations that have been proposed. Do I hear a motion to approve and issue citation number 3 as summary suspension? Do I have a motion?
Move.
I'm sorry.
Sorry, Michael Schattenstein. Hi.
Thank you, Dr. Schattenstein.
Second, Dr. Cacarella.
Dr. Cacarella, okay. Roll call, Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Reddy,
Yes.
and Dr. Bechtel will need to abstain in this citation. We will be considering a citation number 5 separately, so I, Dr. Bechtel, may abstain or vote appropriately. Would any board member like to consider any other citation separately? Okay. Do I hear a motion to approve and issue citation number 5? Do I have a motion?
So moved, Dr. Cacarella.
A second?
Second, Dr. Johnson.
Thank you, Dr. Johnson. Roll call, Dr. Rothermel, Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Cacarella,
Yes.
Dr. Johnson,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
thank you, Dr. Reddy,
Yes.
and Dr. Bechtel will have to abstain again on this. Do I hear a motion to approve and issue citations 1, 2, and 4? Do I have a motion?
So moved, Dr. Johnson.
Dr. Cacarella, second. Okay. Roll call. Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yes.
Dr. Johnson.
Yes.
Thank you. Dr. Cacarella,
Yes.
thank you. Mr. Ganadakis,
Yes.
okay. Ms. Montgomery,
Yes.
Yes.
Dr. Feibel,
Yes.
Dr. Schottenstein,
Yes.
and Dr. Bechtel, yes.
I'm sorry, I don't think I got.
We're going
Dr.
next
Reddy
to
vote.
our operations.
I'm sorry, Dr. Reddy, did you vote on that matter?
I was not asked, but mine is yes.
Thank you so much.
No, yes, I apologize for that.
No problem.
We'll now move on to the operations report. Ms. Luca?
Yeah, thank you. Good afternoon, board members. A quick update for you on our operations. You all have seen your report from a human resources and fiscal planning. We're moving along throughout the year as is expected. We are still in a work from home status and expect that to continue through the spring from what we've been given as direction from Department of Administrative Services. So we will continue to keep you updated on when we plan to come to the office and what that return looks like, we are going to start having meetings about that soon relative to what our space needs are and what our footprint is in the Rhodes Tower when we do return in the spring. So we'll be able to share that out sometime soon. We have not started those meetings yet. They will begin, I think, next week. From a fiscal perspective, you will note, and I will not steal Dr. Schottenstein's thunder for the finance report, but we have an extremely healthy balance right now. And so that's always good news. We like to see a good, healthy balance in our funds. We did have a large uptick in renewals throughout the fall, leading up to that, what everyone thought was going to be the December 1st deadline for renewal. And so we did achieve quite a few renewals in that time period. The balance does reflect a few invoices that we have not yet been charged for this fiscal year from Department of Administrative Services. One of the largest being the e-license rates and number and us paying for our Salesforce platform. And so we received word this week that we can expect those numbers to be shared with us either this week or next week from Administrative Services. So that invoice alone will, I think historically it's been about a $300,000 invoice. We're expecting it to go up a bit, but hopefully not as much as what they originally thought. So I'm hoping for good news from them over the next week. From the licensure staff, and the big news from licensure this month is that our call center, our remote call center is now live and it's working well. So we've had quite a, our call numbers are almost back to a normal status. We had turned the phones off essentially for our work from home status time, and staff were leaving, our voicemails were being received and calls were being returned. We're back to a live call queue at this point. And our licensed staff, as opposed to taking those calls here in the office, they're doing that from home, and it's going very well. As you would expect with calls going up, our emails are coming back down. So people like to be able to make the call, and we're happy to accommodate that. And licensure staff is doing a fantastic job adjusting to that call center from home. We're able to monitor all of that in real time as well. So that's also very helpful for us. Let's see here. In your report, you'll see a new kind of display of the status of our complaints, our open and closed complaints. I hope this is a little bit easier to read and a little more meaningful on the data side. So I think what it can show you, primarily, when I look at this data, what I see on the open complaints dashboard is that our open complaints continue to increase, and our closed complaints are staying about the same. And there are various reasons for that. On the increase in open complaints, for example, while this is a calendar year portrayal, I can tell you our last fiscal year, we saw a 13% increase in complaints coming in. And our close rate was only 3% higher, right? So painting the picture, we're taking more water onto the ship. And, again, we're looking at that from a staffing perspective. We're receiving more complaints. The complaints are complex, and we need to figure out how do we move through the complaints and not close them in a way that we're just closing complaints to close them, right? So the closed data actually tells me that we're closing at a pretty proportionate rate for all of those groups. That makes me happy that we're not just arbitrarily closing cases. It's an indicator that we're not just closing cases just because we're getting in more complaints, right? What we don't want to do is say, we're so busy, we just have to close things without being qualitative about it. But we also know taking on more complaints, we have to figure out what our staffing looks like, and we have to make sure that our workflows are optimal. And so that's really, we talked about what my goals look like for this year. I think back in November, this is really my big focus. Now that we are out of doing a lot of the Strauss Working Group recommendations, I think this is, and this is really a part 2 of the Strauss Working Group recommendations on all of our complaints, is how do we optimally work through these complaints, ensure a quality outcome, but make sure that we're closing things at a pace that we're not taking on too much water. and getting actions more in real time to the licensee, right? Tying that enforcement or closure a little bit closer to the underlying allegation itself. So we'll continue to refine the data. I'm happy to take any questions about that data. It breaks it down really for you by division, where we're holding, kind of our complaints and where the closures are coming from, as well as our top allegations of complaints. There aren't any questions about that. Then the last thing I would just add is that next month we'll be bringing, I think, recommendations to the Medical Marijuana Committee. You might see this in the news over the next couple of weeks. We have received about 30 petitions to add conditions. And so we'll be bringing those recommendations to the Medical Marijuana Committee, who will then bring that to the full board for next steps. The process will continue throughout the summer. What happens is we bring those recommendations, the board determines what sort of category those recommendations go into. Do they need an expert for further review? Have we already asked and answered those questions, et cetera? We will be having a public comment period again, like we did last year. That was very helpful. And after we have that public comment period, then the board will further review the recommendations. That's all from me, Dr. Bechtel.
Stephanie, let's go. Question.
Dr. Jensen?
Hi, thank you very kindly. Stephanie, at the end of April, the FSMB annual meeting starts to take place. And so I was wondering, it sort of snuck up, I think, on us, if there's any kind of preparation we need to do as a board, or if that's something that, board members are interested in.
Sure. I haven't received many details. We do know that the board meeting, that the FSMB annual conference is, I think it begins April 29th. It will be virtual again this year. We don't have any enrollment or cost or other details, but I'll reach out to FSMB this week and see if we can get some information. And then I can, like we do every year, reach out to all of you and see who's interested in attending. And I'm certain that we could accommodate whoever really wants to attend this year, especially given that we won't be paying for travel or other things. So we're happy to have as much participation as needed and desired.
Thank you.
Mr. Kanadakis?
Thank you. On a different matter, Stephanie, at the beginning of your presentation, you indicated, and I apologize if I misinterpreted, but a spring return date for our staff. Do we have a date specific for that, or a range, or a goal, or have you been given any counsel or guidance from the administration?
So we were always in phase 3. So phase 1 was going to start January 1st, and phase 2, I can't remember the date. Phase 3 was going to start the last week of March into April. I know phase 1 got delayed. We have not heard and we know that there's going to be a trickle down return on the phases. We haven't heard what the official date would look like. We have been encouraged to let our staff continue to work remotely until Memorial Day, if we can accommodate that. So regardless of what our return looks like, they've encouraged us to continue in a remote status until Memorial Day timeframe. But by the time I think that we plan and we have 2 floors in the roads now, as we have these conversations about like what does a remote workforce look like for, let's say, the call center. We might be able to save a floor. We might be able to save on being part of the 2nd floor at the Rhodes Tower. That will probably take a couple of months planning. So I would like us to be ready to go with whenever it looks like the date they tell us we can return.
Okay. Thank you.
Ms. Montgomery?
Thank you, Dr. Bechtel. First of all, I want to just commend your staff. The charts are easier to read and understand. I know that that's probably a difficult process to try to figure out how to make it work. And I also commend you on your new hires, both Jim and our new compliance person, Brandy, look to be solid. You are assembling a team that is, I think, it's very impressive. And we've got a lot of details with different priorities. And so far, I have to say to you, I'm really impressed with what you've been managed to be able to do in one short year. And obviously, we have a lot to go, and staffing and figuring out processes that are more timely. But congratulations to the staff. This has been heavy lifting in the middle of a pandemic. Well done. Thank you.
Thank you. It is, it's a fantastic team, and they work really hard, and things are kind of constantly coming at us. It's been exacerbated, as you said, by the pandemic. That's extremely challenging, I think, for all of us. But the people are doing a really, really terrific job of keeping things moving.
Thank you, Ms. Luke. I would like to second what Ms. Montgomery has said. I think, again, you provided great leadership. You put together a great team, and at a time with the COVID-19 crisis and things like that, you've done really an outstanding job, and we're very appreciative. I thought we'd move now to the Rules and Policy Committee. Do I hear a motion to approve the draft minutes of the December 9th, 2020 meeting of the Policy Committee? Do I have a motion?
So moved, Dr. Johnson.
Dr. Johnson, second.
Second, Dr. Safran.
Dr. Safran, thank you. We just need a voice vote on this. All in favor, say aye.
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 Any opposed? Okay, thank you. I thought we'd move forward now with the rules review update with Ms. Anderson. Thank you, Kim.
Have the materials that have historically been given to the policy committee, so we'll be doing those in this portion of the board meeting. And the rules schedule just gives you kind of an idea of the outstanding rules and where they are. We'll talk a little bit more about the CME rules later. We've had a little bit of a wrinkle with those with some of the new legislation. And we'll talk more about the rules that we're sending out for initial circulation and weight loss rules that are pending at CSI. I can also let you know that in last week in early January, we did file an updated business impact analysis for the hearing rules to address the change that the hearing unit had requested to be able to do remote hearings on motion. And so CSI did ask us to file an updated BIA on that, and they're currently out for comment. And so we'll let you know if we get any comments on those. But other than that, this just gives you a snapshot of what we're working on this year and what we're working on right now. So no action unless you have questions.
Thank you. I thought we would.
I'm sorry, Kim, do we need a motion to circulate rules amongst interested parties?
Yeah, actually, if I could, I've got more rule things I'd like to talk about if you're ready for me.
They'll be fine, Ms. Anderson. Yes.
Okay, great. So I would like to talk about the rules for initial circulation that you have in front of you. And I will need a motion and a vote for that. I wanted to just give you a high level explanation. So basically at this point, I've gone through and looked to see if there are technical changes that we need. There were a number of rules where our statutes had changed, and so we needed to make some changes there. In the delegation rules, 47, 31, 23, those rules, there was a rule that talks about statutes that are used by the Department of Developmental Disabilities, and many of those statutes had been repealed. So I did reach out to the Department of Developmental Disabilities, and they have requested that we make some changes by deleting their provisions from our rule and adding in a statement that basically they don't want physician delegation of medication administration in their facilities. So that's something that doesn't work well for them. And so they're recommending that we add something that says that physician delegation is not applicable in those facilities, which is fine. You know, they have more particular rules that deal with those facilities. So we will propose initial circulation with those changes, and I'll show those to you next month as well. But that was probably the biggest change. And then we've got a few other things where we're just updating statutory authority. We're changing, you know, places where it's a license. We used to call it a certificate, and now we call it a license. So just making those changes as well. So if the board members are generally okay with these changes for initial circulation, we'll send those out just to start getting the initial comments back, and then we'll come back to you before we do any official filing.
Ms. Anderson, do you need a motion for that?
I would like to have a motion if I could.
Okay.
I think the voice vote's okay though.
Okay. Do I have a motion?
Move, Dr. Schottenstein.
Okay. Thank you, Dr. Shen. Second?
Second, Dr. Cacarella.
And we can do a voice vote. So all in favor, say aye.
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 Okay. Thank you.
Thanks very much.
And then would you like to present, Ms. Anderson, the comments on weight loss prescribing rules?
Right. Actually, I'd like to see if Dr. Soin can help me with that. He's been really involved with working with the people who were interested, and I'm not sure I see him here. Oh, there he is.
Yeah, I'm here. It's just my internet
Okay.
was running a little slow, so I turned off my camera and it seemed to be better.
Okay, good.
Yeah.
But yeah, Dr. Soin, I didn't know if you wanted to present this.
Yeah, I do a little bit. I'm going to try to turn on my camera so you guys can see me better. And if I slow down, I'll just turn it back off. There we go. You know, my kids are streaming their school also, so I think it has a strain on our bandwidth right now. So, you know, this thing with the weight loss rules is something that we've really been trying to dig deeper into. And we've talked to multiple people who have been involved in these prescribing of weight loss drugs. We've talked to pharmacists, we've talked to people from associations to really get a comprehensive look. And it basically boils down to a couple of points that seem to be the most pertinent. In other words, all of the comments kind of generally can be filtered down to two basic families of issues. One is just the fact that, you know, phentermine is, in our rules, can be used for acute weight loss, but there really isn't a mechanism for it to be used chronically. And that is causing some issues in terms of access because that drug is off patent. It's very cost effective. And some of the people involved in this seem to indicate that it's actually rather helpful. On the same token, there's another drug that is actually FDA approved for chronic weight loss, so they can prescribe it chronically, called Qsymia. And interestingly, in Qsymia, they actually have phentermine as part of that drug. So those individuals that are providing us feedback, Qsymia is actually a mixture of a drug called Topamax and phentermine, I believe. But they're coming back to us saying, look, you know, you've already approved this drug for chronic use, but it's not generic, so it's extremely expensive. And then, you know, we can't use it. We can't use a generic one for chronic use because the FDA hasn't labeled it for chronic use. So that's caused some, you know, concerns and issues, and it's something that we have to mitigate or sort of perhaps talk through or realize what we want to do about that, because the phentermine actual drug is one that is abused and diverted and has caused some issues. There are neighboring states to ours that, for example, like in Kentucky, that don't have as rigid rules as Ohio does. And there's actually cohorts of patients that come from Ohio and drive down to Kentucky to get those medications and then, drive back over the border. And interestingly, that was something that was brought up by one of the key opinion leaders during a conference call I had with them about that fact. So we want to protect the public. We totally understand and the challenging issues with obesity. But that is a piece that we're trying to wrap our heads around in terms of what to do. And then the second family of comments were really about how our rules are in terms of face-to-face visits. Is there opportunities to expand telehealth, telemedicine, some sort of remote exchange where the visits don't necessarily have to be face-to-face all of the time? And that was sort of another point and topic of discussion. And we got that information, and we, over the last month, we're trying to digest even more information about those various things, which we have done. And now that's where we are now, and we have some comments. And when we had that initial conference call, we kept getting in comments, even past the date where we were saying, okay, let's have our comments in by here. And that's why we sort of deferred it to this month. And now we have even more comments that you see. There's also an article on the long-term phentermine use. It's actually pretty good to look at here in our board materials. And so where we're at is where I just described. I think from a board standpoint, with all the issues we've had with prescription drug abuse, I candidly don't know how board members want to proceed or what we want to do regarding the chronic use of the generic phentermine, if it's appropriate, if we should keep the rule as is, if we should perhaps allow it, but put very rigid controls around it, similar to how we do with opioids, or if we just allow open access. I mean, those are all opportunities. And I think this is a thing that's probably going to take a lot of time, research, and discussion to understand it more. I learn more every day. Even reading that article on long-term phentermine, I learned some new stuff, and I learned about how FDA approval works, chronic versus acute. And some of that is actually more strategically from a pharmaceutical company. In other words, when a drug is generic, there is no motivation to get that drug relabeled for chronic use because there's no financial incentive to do that, which puts people in sort of this infinite loop of not being able to get that label. And that's actually all the comments I had.
Any other comments on weight loss? Dr. Reddy.
Now, weight loss is a big issue. It's and Ohio has the much more obesity than the general population in the U.S. I do think that we need to do something. Obesity has to be considered as a disease rather than cultural or any else way. And I do think that the medication part of treatment of obesity is very essential. And we do have to consider, just like treating chronic pain, we should allow prescribers to use phentermine for long-term use, but should have strict controls how they use and so forth. Obesity is affecting quite a few of the Ohioans, and I feel very strongly about it. We have to control obesity. We have to treat it. It falls upon us to bring guidelines up to the mark. I have read all the details, particularly with obesity. I spent a lot of time, and I do think that we should consider something going forward to help reduce the obesity.
I forgot to mention one more thing. I'm sorry. I know other people wanted to talk, but I got so caught up in describing the past. I forgot to mention what I was suggesting or wanting to do going forward. And that is, I wonder if we should be getting more data and information, particularly about neighboring states, in particular, like states that do have open access, and like what is their prescribing pattern and what does it look like? I can tell you, being in Dayton, Ohio, I actually know of, heard of, and seen a lot of people actually driving down south right to Kentucky, knowing that they can very easily obtain medications. And that makes me a little bit nervous and apprehensive. So I wonder if allowing open access or allowing more access to this is something that we need to take cautiously, and perhaps we need more information to understand what impact that would have by looking at other models that have rules that are different than ours. I don't know if that's possible or practical, but I think that would help us, because if there are ways that we can do it and keep a box around it and be safe, then I think that's okay. But if you see just a hockey stick of prescriptions, I don't know if that's okay, and it's probably worth a discussion.
Mr. Gacaloni?
Yeah, I would agree with you, Dr. Soin. Here's my concern is, we had open access before, and it created diet clinic pill mills. Okay, so we ratcheted it down. And my concern here is that, this could be just like the opioid situation, especially if we leave this diet pill prescribing to every physician or PA or whatever out there. If it's a specialty, kind of like pain management specialty, a bariatric physician or whatever, I might consider it. My concern is when you open it up to everybody and we just let it, wide open, I think we're asking for a problem.
Dr. Schoenstein?
Hi, thank you. So, I'm certainly respectful of the comments that were in favor of expanded access to phentermine. At the same time, it sort of rings in my ears that there was a time when the addictive potential of opioids was really minimized. And so I don't want to find ourselves in that position with the phentermine. Lots of well-meaning comments about how the risk of addiction with phentermine is low. And it just rings in my ears that the same thing was said about the opioids. So I want to help, and I want to expand access, and I certainly think it's important to treat obesity, but I also feel like it's worth investing our time to proceed cautiously to make sure that we don't, open up a Pandora's box of problem with this.
Dr. Ravi?
We have a specialty which is obesity specialty, family physicians, internal medicine specialists who specialize in treating obesity. If we just consider them to be the physicians who control prescriptions, that might be a way to go forward. Not opening up for everybody to prescribe this particular medication, just like we use opioids right now, that there should be a consultation by the pain physician in the chart if a general physician wants to continue the treatment. We could use a similar approach to obesity medications too.
Dr. Soin, do you know if there's been any effort to look at states that approve phentermine for chronic use for weight loss? If we've looked at best practices with them, if there's any states that have not run into issues with abuse, to see what their guardrails are or outlines are to help minimize abuse and diversion.
Yeah, so as you know, we go through this process every couple of years, and the last time we went over this rule, I don't remember how many years ago, we did look at some neighboring states, in particular Kentucky, and I don't recall the data off the top of my head, but I do know that it was very compellingly significant in terms of the number of doses that was prescribed there compared to Ohio when you look at the number of people that live in the state. And that caused us all to pause and be concerned about it. And I think when I was proposing next steps, I suppose that might be a good one, is for us to consider to look at some other states or see what other data we can get, and then perhaps use that to help guide us on next steps. And I think it's fine to continue to defer and table this topic to make sure we get it right, as long as we're not breaking any rules of of timeliness. But that's what I feel.
Okay, thank you. Mr. Gacaloni?
Dr. Soin, one other follow-up question. You mentioned Kissimmee, which is a combination product with phentermine, and another one. were you able to talk to the manufacturer at all? Because my one question is the combination of the two which drives the chronic, long-term use and the concern against addiction, or is it something else? And I understand the comment, and it's absolutely correct about you have a generic product, no one's going to put the extra time and effort or money, more importantly, behind getting a new indication. But that indication was found through clinical studies that were submitted, and that's why you have the limitation in the FDA labeling for phentermine. My question is, were we able to get anything out of the reaction that said the combination is what makes this less of a concern?
So I have not yet, but now I will. So next time we bring this up, I will have an answer to that specific question.
Okay, thanks.
Ms. Anderson, I thought we might go on next to the CME rules.
Sure. And just so I'm clear, so I think I can continue to work with Dr. Soin, and I think what we could do is do some legal research on rules of other states. And then I think we also may need to reach out to the Board of Pharmacy and see if we can get some, if it's possible for us to get some pharmaceutical data from other states. I know we were able to get that last time from Kentucky, I think through the CASPR program. And so I think maybe those are kind of two avenues that that we should follow and come back to the board with some information. Does that work? Is that what you're looking for?
Yes, I think it's important to look at states in which phentermine has been used on a chronic basis, in which there has not been issues, and how do they structure that, and what are the guardrails they put around that prevents abuse from occurring. And when you look at the situation in Kentucky, it does give you pause about using this drug for chronic use, but maybe we need to look at other states also in which it's been used successfully, and then make a final opinion.
Okay. All right. I'll work on that. Yes, Mr. Giacalone.
One last thing. All the comments are very positive. Everything's positive. Everything's great. We need to use it. I haven't seen any negative comments, and they're got to be out there. I want to see what are some of the problems with this too, which aren't articulated.
Yeah, in our initial, so these are the comments that we've received from the bariatric physicians. In our initial circulation, we did receive comments from the Board of Pharmacy supporting our rule as is.
No, but I'm talking about beyond just our state.
Right.
What's going on in other states where they've seen issues and what those are, because we don't want to, if we go forward with this, we don't want to replicate something that's already happening now, right? Because our data on what's happened in Ohio is somewhat dated, because it's a while back. These rules have been in place for a while. I'd be curious to see, what's going on in a state where this is, no offense, hot and heavy, and there's a problem. We should know that, and what they're seeing and what they think they should have changed.
Okay. We'll see if we can get that information.
Awesome. Thanks, Kim.
Okay.
I thought we'd go on then to CME rules.
All right. Thank you. So I'm pulling those up right now. House Bill 442, which we talked about a little bit this morning about some of the changes that occurred based on the massage therapy curriculum. House Bill 442 also is impacting our CME rules as well. So there were changes made to the requirement for CME for clinical research faculty holders and in the volunteer hours. And so we were going to be ready to have you adopt those rules today, and because of those changes, we are not. So I've got amendments for two of the rules, 1002 and 1008. So I would like approval on those amendments. And I did TBR those two rules at JCAR. So we will refile them as amended, and then we will come back to you for final adoption. I think we're going to have to wait until early April to get that done, because that's when the changes in 442 will be effective. So what I'm looking for today is approval of the amendments to 4731-1002 and 4731-1008.
Do I have a motion?
So
Moved,
moved.
Dr. Johnson.
Dr. Cockrell and then Dr. Johnson, thank you. And then I guess Kim will probably need a voice vote, is that correct?
Yeah, a voice vote is sufficient.
Okay, all in favor, say aye.
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 Opposed, say nay. Thank you.
All right, thank you. We'll be back to you with those in the spring.
Thank you very much, Ms. Anderson. We appreciate it. And now I think we do our legislative update next. Chelsea, do you want to go ahead and?
Yes, thank you, Dr. Bechtel, and thank you for allowing me to provide the legislative update before you all today. The past month was extremely busy as the 133rd General Assembly wrapped up business for the year. There were a few bills that were passed that will have a significant impact on the medical board, and staff is currently in the process of reviewing the impact of these bills on operations, and we will be reporting back on what steps will be taken to operationalize these new policies. Senate Bill 310 was the capital appropriations bill and also disperses federal COVID funds. The language in the as-passed version included amendments that waived supervision agreement requirements for physician assistants and advanced practice registered nurses, allowing those individuals the ability to work with physicians other than those with which they hold a supervision agreement. This is only to occur in hospital or medical facility settings. Additionally, that bill allows retired medical professionals to practice temporarily without reinstatement of their license during the pandemic. The language also included a provision that excludes those whose license had been previously suspended, revoked, or surrendered to avoid disciplinary action. All of these provisions will be effective until May 1st, 2021, unless they are extended. House Bill 263 create licensing opportunities for individuals with former criminal convictions. This language places limits on the board's ability to deny a license solely based on a prior criminal conviction. The new law requires that the board create an inclusive list of criminal offenses that would prevent an applicant from becoming licensed. There are also some new reporting requirements for the board to report data to the Department of Administrative Services. And House Bill 442, which initially applied to certified public accountants, was amended late in the legislative process and removes Oriental medicine practitioners and cosmetic therapists from under the regulatory authority of the medical board. As Kim mentioned earlier, there was an amendment included that also reduced the education hour requirement for massage therapists, made changes to requirements for clinical research faculty certificates, and increased the number of volunteer hours that may be applied for continuing education credit for physicians. You'll find more detailed memos on each of these bills in the board materials. Please note that the effective dates on House Bill 442 and House Bill 263 are incorrect on the memos. The governor signed those bills after the documents had been uploaded to Onboard, and they will now be effective in early April. The policy and legal teams continue to review this legislation and are holding operational meetings to strategize the implementation of any new requirements. You may have also noticed that my regular legislative tracker is not included, and that's because no bills have yet been introduced this year. The online tracker is up to date for the last General Assembly, and you'll see that there's a new tab for the 134th General Assembly. I will be sending, or resending rather, the links to the tracker along with that instruction guide, just to be sure that everyone has access. Since the end of the lame duck session, I have been working on legislative outreach. One of the priorities of the legislative team for the 134th General Assembly is improving our relationships with members of the legislature. I have been working to contact all incoming freshman members to welcome them, and I will continue to build relationships with existing members, prioritizing those members who are assigned to committees relevant to the medical board. As far as policy priorities, we are working to continue to progress the sexual misconduct draft that resulted from the Strauss Working Group. We have had conversations to address concerns with several stakeholders and anticipate further conversations as we continue through the process. Additionally, telehealth is among our top priorities for the coming months. That concludes the legislative update, and I'm happy to answer any questions. I think I saw Ms. Montgomery.
Ms. Montgomery.
I'm sorry, Ms. Montgomery, you're muted.
Heaven forbid. I wanted to just say you have really done a wonderful, you and whoever worked on getting these bills in shape. As you look through, I guess it's if you look through 310, and let's see which number that is. 263, House Bill 263, and then it's been clearly, carefully, a lot of our issues were addressed in one way or another in checks and balances. And but I frankly am very impressed at the quality of the depth in which these bills have been addressed. I know there are questions to be answered in that, but well done to you. This is, I think we're in less jeopardy than we were, in my opinion, than we thought we would be last month with these bills. And I think that's because of your hard work. And it's unclear to me is do we have to, in which bill we have to, in 263, do we come up with the disqualifying offenses so we can protect ourselves that? Correct?
Yes. So we are tasked with creating that all-inclusive list. The list is required to be completed. We have 180 days from the effective date for that list. So we have some time to work on this and really, take into account which offenses we want to spell out as, important to us to prevent someone from being licensed.
So, it looks as if we have some buried within the bill, some ability to protect the issues that we were greatly concerned about, which is wonderful. In House Bill 442, it's not clear to me when I read your memo and Kim's memo, and it may be just a summary that you've given. We require, we modified our CME rules, I guess it was last month, and said you can have 10 hours of volunteer work that goes towards your 50 hours. If I'm correct, please correct me if I'm wrong. If in the summary, it sounds as if that was a one-on-one, but then in 442, the summary says, wait a minute, you'll have to work 5 volunteer hours to come up with 1 hour of CME. But it doesn't sound as if there's a curve, and it may be just simply in the summary. Is there a curve on how many, can you do 50 hours, essentially 50 hours of work can you fill all of your CMEs under House Bill 442 with volunteer work?
That's not the way that I read it, and maybe it's the summary that's not really explaining that well. And please correct me if I'm wrong, Nate or Kim. It's my understanding that you can do up to 10 hours of volunteer at that 3-to-1 ratio.
Okay. So we've got a curve on.
Yes.
And you've got to understand. I think it's, although it's alarming to us because we want medical education to be primary, we're in a pandemic, and so the policymakers have made that decision. But well done. I thought, generally speaking, this language, we've got some questions. I assume we can do some cleanup with some amendments and new legislation as we address those. But well done. I thought you did a great job, and you and whoever helped passing these bills.
Thank you. I appreciate that. And I think it would be remiss not to mention that this was a team effort for sure. I had a lot of help from Nate Smith and Jill and, Sierra on things. So I want to make sure that they get credit as well.
Yes, Ms. Muncy,
You don't see a lot of this legislation when it's major. So many times it's just a sweeping general language, but it doesn't address the niggling problems that we then have to address. But obviously you folks did that. And just remarkable. Well done.
Thank you.
Ms. Muncy, I share their opinion also. I think your legislative team has done a great job in presenting this information to the board. And we just feel, I think, a lot more informed, a lot more engaged than we have been in the past. And we appreciate that. Thank you.
Just a question, Dr. Bechtel.
Yes.
It's 3 hours of volunteer for 1 hour of CME.
I thought it said 5 hours.
5 to 1.
Yeah, for 1 hour.
It is. I apologize. I think I said 3 to 1 just a moment ago, but it is 5 to 1. I misspoke.
Up to 10 hours of the 50.
Yeah.
Correct.
Yeah, so you'd have to do 50 hours of volunteer work to get 10 hours of credit. That's correct.
Okay, I was confused. I'm sorry.
Thank you. Dr. Sunstein.
Hi, I'm curious about the list in 263 and whether or not when that 180 days is up and we present a list, if that is final or if we're allowed to revisit the list.
I would imagine, it would have to be a legislative change, but if we need to revisit the list, we could do that through legislative means.
Oh, okay, thank you.
So I guess just a quick comment on the list. The list has to be directly related to the duties and responsibilities of the occupation. So we'll probably be looking at coming up with a list for each license type. We also have rulemaking authority to implement this chapter. So, but I think that's a really good question from Dr. Schottenstein is, what would happen if a new crime gets enacted into legislation 2 years from now that could be directly related to our licensees. And that's something that we're considering and looking at. So thank you for that comment.
Thank you.
Even though, and Nathan, even if it's not a new crime, we may learn that in fact our list is incomplete, that some egregious thing happens and we say, holy cats, we probably should include this on our list. So perhaps that just goes on your amendment list to try to figure it out in the new General Assembly.
Thank you.
Thank you. Any more legislative issues to bring up at all? I thought we go on to the Physicians Assistant Policy Committee. Ms. Riordan, would you be able to give us your committee report?
Thank you, Dr. Bechtel, members of the board. The Physicians Assistant Policy Committee was held on January the 8th. The minutes from the prior Physician Assistant Policy Committee were approved by the committee. A legislative update was provided by our Legislative Director, Chelsea Wonsky, and our senior legal counsel, Nate Smith, presented a group of initial circulation rules, the weight loss rules, and the light-based medical rules for discussion and comment. And these are the same rules that Kim was addressing earlier. The PAPC discussed these 3 sets of rules. Their comments will be taken into consideration. And then with all of the public comment will be brought back to the board at the appropriate time for review and decision. The next PAPC meeting is scheduled to be held on April the 9th. And that is the end of my report.
Any questions? Thank you, Mr. Riordan. We'll go on next to to Dr. Soin with the ICD-10 Code Data Review Committee.
Thank you. The ICD-10 Code Data Review Committee met this morning. We'd actually met previously in 2018 and 19, and in 2020 with everything else we had going on, we hadn't met. We reviewed the what we've done in the past and what some of our goals and objectives are. And going forward, what we wanted to do was to, first of all, with at some point in the future, one of the medical board e-news, we're going to discuss the importance of the initiative of ICD-10 codes, and provide the link on where you could click to see the database of ICD-10 codes. And then the second major thing that we wanted to do was actually take an inventory on physician outreach that's already occurring, because as was mentioned in the meeting, if you write opioids and you have an ORS account, you actually get an email that benchmarks you against other physicians. And we just wanted to know and understand what all types of communications and mailers are going out to physicians. That way we can adequately get our messaging on the same place without reinventing the wheel. So the two major items, for next month would be, or next time we meet, I suppose, would be our outreach to all of our licensees through an e-news type of thing and an inventory. And then we're going to decide how best to get messaging out there. And that concludes my report.
Thank you, Dr. Swain. Any questions for Dr. Swain? Thank you. Ms. Montgomery will now have you give the Compliance Committee report.
Thank you very much, Dr. Bechtel. We had essentially two items, main items. One was to approve the contracting, the approving of the use of Glen Bay as one of our treatment providers. It has 6 locations. It has a full suite of services, both residential and non-residential in one of the sites, and the other ones are all outpatient. That was the recommendation for the board to approve, was moved and passed. We also addressed the question that we got a letter from the OPHP, and that was a conversation, as all of you have seen the letter, that it reflects some ongoing conversations many of us have had about the cost of referral for where we think that a licensee has a substance abuse problem to do an evaluation. That cost thus far is a 3-day residential at $4,000. And we have currently, under the rules, exempted the need for the 3-day in residential evaluation for massage therapists, because they are so low on the salary scale compared to some of our other licensees. That led to a conversation about, in this OPHP, was to say, look, if you look at your registered I'm having a senior moment. Your RCPs, registered
respiratory
care professionals. I'm sorry. The respiratory care professionals, ODHP, is saying, look, they are working enormously hard in the midst of this pandemic. They are in the same boat essentially as your massage therapist. Would you consider allowing an exemption for them, which led to a broader conversations about perhaps what we need to do is do an evaluation of who is required to do a residential evaluation versus 1 day as a general for all of our licensees, our allied professions, and B, perhaps we should also look at the efficacy and the difference in the efficacy of a 1-day evaluation versus a residential wraparound 3-day evaluation. So that is something that the staff will begin to work on to make some recommendations to us as they pull together some research on that. And we began to look at the broader question of who is required to do 3 days. Should 3 days be required? How good is it versus 1 day, and cost, etc. those are the two items that we essentially talked about in the compliance committee.
Ms. Montgomery, can we have a vote to approve the committee's recommendation?
Yes.
To approve the application for Glen Bay to continue as a treatment?
Yes, I was just waiting to see if the chair wanted us to do that now, and if you want us to.
My apologies.
Yeah, I thought we could go ahead with it now, Ms. Montgomery.
Okay, so that being said, the recommendations are to certify Glen Bay and accept them as a treatment provider. And I guess what we would ask is all those in favor say aye, and opposed same sign.
I think
we will need a motion and a second.
So moved.
Second.
Accept Glen Bay.
Thank you.
And it's been seconded.
Yes.
All in favor?
Aye.
Aye.
Opposed, same sign? Okay. And then the OPHP doesn't require, I don't think, at this point, we did not hardly come to a conclusion of whether the we did not make a recommendation at this point to whether the RCP should be a part of the exemption, such as the massage therapists are. So I'm done, Mr. Chairman, Dr. Chair.
Okay. Thank you, Ms. Montgomery. Thank you. Dr. Schottenstein, we'll have you give the FSMB Recommendations Review Committee report.
Sure. Thank you so much. So we had our initial committee meeting this morning, the FSMB committee, and we'll recall that the State Medical Board of Ohio engaged the FSMB to audit our processes as part of our Strauss Working Group recommendations. And among other things, they had two substantial recommendations for the board that we are going to be addressing in the committee. The first was a recommendation that we reconstitute the Quality Assurance Committee to audit our closed cases. And I say reconstitute because you all may or may not know that I want to say it was back in the 90s, maybe from like 1993 to 2003, something like that. We had a Quality Assurance Committee and it folded. We're not exactly sure why. I have my own thoughts about it because when I look back through old minutes, there were never any findings that were shown when I look at the minutes about concerns, about discrepancies or things like that. And I wonder if essentially after time, people simply became satisfied that everything was proceeding correctly and then just decided to sunset the committee. But in any case, it was a recommendation by the FSMB that we reconstitute that committee. And then the second recommendation that they had was that there be public member involvement in the assessment of complaints. And I think that essentially what they're recommending is that we have a public member team up with the secretary and supervising member, sort of a third voice in the process. And I think their preference, that is to say the FSMB's preference, would be for that public member to have input in terms of all complaints that come through our door. But we also talked about how that would be a very substantial increase in workload for public members, and we want to be cognizant of that. And so even though you certainly could understand how it makes sense to have public member involvement all the way around, we also had the thought, and I don't want to speak for the committee, but it seemed like where the consensus was firming up was that maybe we start out having public member involvement just in the sexual misconduct complaints to start. And depending on how many of those complaints we get a year, maybe a public member would volunteer to do those, or maybe we would potentially rotate our 3 public members through and divide those up. Again, trying to be sensitive and respectful to the amount of time that is being additionally asked. And so, the goal, of course, is to give the public confidence in our system. It's not that our current system is broken in any way. It just provides additional transparency and potentially is meaningful in that way. So there is public how shall I say, there are public staff and members who may have involvement in these cases along the way. But conceivably, it's important to have that involvement in the closing of these cases. I think that's where it's potentially really helpful. So, so just quickly then, in terms of the Quality Assurance Committee, what we talked about was essentially getting a certain percent of cases from the previous month that were closed and randomly dividing those, randomly dividing those up among committee members. Committee members conceivably then would read through the complaint and the investigation information, and then essentially write out some thoughts about whether or not there's any discrepancy about how that case was handled, and then all of that feedback could be brought to staff, who could then potentially present that to the committee at the following meeting, and then that could then be reported out to the full board as to whether or not we found anything that was of concern. And somebody in this morning asked a good question. I think it was Dr. Saffron, who said, well, so what's the point? In other words, let's say somebody has a discrepancy. What do we do with the case? Well, to me, it sort of makes sense that if there's a discrepancy that is brought up, that case go back to investigations again to have another look. So that's where we left things, and that concludes my report. Any questions about any of that? Okay, thanks everybody.
Thank you, Dr. Schonstein. I thought we'd have you go on now to give the Finance Committee report.
Thank you so much. So Stephanie already alluded to some of this earlier, but looking at our fiscal update for November 2020, revenue was $1,993,827. $1.8 million of that was license renewal. So that improved revenue is substantially a function of license renewals by licensees who'd put off their renewals, but then started to renew in anticipation of the December 1st deadline. So although that deadline renewal was once again delayed until July 1st, that additional delay was announced so late that our licensees had basically all renewed by that point. So we are essentially caught up from that previous licensure renewal deadline delay. It may be that we will once again have a drop-off in revenue because of the additional licensure renewal deadline delay, but we have a pretty good cushion in our finances now and should be able to manage that. So you may have seen that our cash balance has again improved at $6,828,732. That is by far a record for us. You may see a 6.3% decrease in year-to-date expenditures, and Stephanie alluded to that as well. There has been that delay in receiving invoices, not just from DAS, but also from the credit card processors of our licensure fees. They are our two biggest payees. So outside of payroll, we only had $25,000 in expenses. Usually that number would be around $100,000. So non-payroll expense will start going up in December and January as we get invoiced for all of these charges. We do continue to explore the option of licensure staff working from home on an ongoing basis, which would allow us to give up our space on the second floor and reduce our expenses in that way. And it may be potentially at the February meeting, we'll have Finance Committee get together to contemplate changes like that. So we still have not received feedback on our budget expansion request from OBM. We are awaiting that, but I think that would also be a prudent way to spend down some of our balance. So, of course, we've talked about House Bill 442, with the removal of the Oriental medicine practitioners and the cosmetic therapists from our purview. The Oriental medicine practitioners potentially will simply re-up as acupuncturists because we still manage that. The cosmetic therapists, I think, are going to the cosmetology board. This is going to result in a loss of revenue to the board of an estimated around $30,000 per year. In terms of disciplinary fines in the month of November, we received $24,000 in addition to $4,436.52 received from collections. We levied $28,000 in fines. We've received $138,920.04 in total fines year to date. And finally, you may see documents regarding our board member compensation policy in the onboard software. We typically review that roughly every January or so in Finance Committee. And as I think may have been mentioned, board member compensation in aggregate has actually gone down fairly substantially due to the decrease in travel expenses from the pandemic. There's no new business. Any Finance Committee related questions for me? Okay, thanks kindly, everyone. That concludes my report.
Thank you, Dr. Schottenstein. That's great. Dr. Safran, we'll have you address the licensure committee business.
Thank you, Dr. Bechtel. Today for board consideration, we have 8 licensure requests. Information on each of the requests has been prepared by the licensure staff and distributed to board members. Does any board member wish to consider any of these applications separately? Not hearing anything, do I hear a motion to approve the licensure staff recommendations for the requests of Nadal Akib, MD, Kimberly Ferguson, Tori Grant, Naja Mehdi, MD, Gerald McCullough, Devonna Paris, Jesse Pruitt, and Jamie Russell? Do I hear a motion?
So moved, Dr. Schottenstein.
Dr. Schottenstein, second, Dr. Caccarella. Is there any discussion? Okay, a roll call vote. Dr. Rothermel?
Yes.
Dr. Safran, yes. Mr. Giacalone?
Yes.
Dr. Soin?
Yes.
Dr. Schottenstein?
Yes.
Dr. Johnson?
Yes.
Dr. Caccarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Reddy?
Yes.
Dr. Bechtel?
Yes.
This concludes the licensure report, and just one note is that all 3 of our consumer members are doctors and can be called the doctor, just for the sake of discussion.
We don't get no respect.
You do for me.
Thank you, Dr. Safran. Next on the agenda, please turn to the compliance section, the office conference review. Do I hear a motion to approve the compliance staff's reports of conferences for December 7th, 8th, and the 21st of 2020? Do I have a motion?
So moved, Dr. Caccarella.
Second?
Second, Giacalone.
Giacalone, Mr. Giacalone, thank you, sir. And all we need is really a voice vote. All in favor say aye.
Aye.
Opposed?
I abstain.
I abstain.
Okay. We'll go next to probationary requests. At this time, we will consider the probationary requests in today's agenda and have been prepared by the standards review and compliance staff and distributed to board members. Marvin Balula, Brent Boyer, Mary-Jo Ellen Erickson, Yamini Jadcherella, Robert Rasmussen, DO, and Siraj Siddiqui, MD. Before asking for a motion, does any of the board members wish to consider a probationary request separately? Okay. So do I hear a motion to approve the secretary and supervising members' recommendations for probationary requests? I'll need a motion.
So moved, Dr. Caccarella.
Well, thank you. A second?
Second, Dr. Schottenstein.
Dr. Schottenstein, thank you. And we'll have a roll call. Dr. Rothermel?
Abstain.
Dr. Safran?
Abstain.
Mr. Giacalone?
Yes.
Dr. Soin?
Yes.
Dr. Schottenstein?
Yes.
Dr. Caccarella?
Yes.
Mr. Ganadakis?
Yes.
Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Reddy?
Yes.
Dr. Bechtel abstain. So this concludes the January 13th, 2021 meeting of the State Medical Board of Ohio. Do I hear a motion to adjourn?
So moved.
All in favor, say aye.
Aye.
Opposed? Thank you.
Did a great job, Dr. Bechtel.
Great job. All the best.
This conference is no longer being recorded.
And the meeting is officially adjourned at 2:11. Thank you very much. Thank you so much.
Good job. man.
Happy New Year's, everybody.
Happy New Year, everybody.
Stay well, please.
Thank you, Ben.
Take care.